clinical trial I will try to cover here. So for major clinical trial for a systemic setting, you can see, and then checkmate 214, double IO, and the 3 trial for IO-TKI combination as well here. And then if I have time, I'm going to talk about the second line option as well, and hopefully adjuvant treatment option as well. So those all medication has been approved by FDA. That you can see from 2018, we have a huge treatment landscape change for the RCC. It's luxury time for the RCC. We have many options available right now. So I think you already heard about this slide. I'm just going to pass this one for the sake of time. So yeah, the RCC, it is like, I think around the world is like 440,000 cases in a year globally. And in the United States, 82,000. So this is, I think, the 6th common cancer in the male and the 9th common case cancer in the female. And the incidence is rising because of the diagnostic test and early detection, thankfully. So, and the median age is around 65. So actually male has more common kidney cancer than the female. And this is the survival data for 5 years. And you can see, the kidney cancer is treatable disease and the life expectancy is higher with the new advancements as well. So if there is localized disease, there's a chance of having 5-year overall survivals over 90%. When it's actually distant, this can be dismal sometimes, but this is improving, thankfully. So how do we treat advanced kidney cancer? So, and we're going to talk about the systemic immunotherapy and targeted therapy. So before I talk about the systemic therapy, I think this is the most exciting slide. I guess you all want to hear about it, how those medications really work. There is 2 different drug peers, immune checkpoint inhibitor, and there is a tyrosine kinase inhibitor. So this slide is actually, the cancer cell is a very smart cell. It's hiding from the immune system by communicating with the T cell. There is a communication between these 2 cells by PD-1 receptor and PD-L1 receptor. And this discovery actually led to the Nobel Prize, 2 smart scientists, one from MD Anderson, Dr. Allison, and the other one from Japan, Dr. I think, Huso, if I'm not mispronouncing. So he got, both of them got the Nobel Prize in 2018 because of this pathway discovery. And later, some of the smart scientists come up with this monoclonal antibody targeting this receptor, and which include like pembrolizumab and nivolumab and ipilimumab. So, and this the way that we actually break this communication and then activate the T cell and find those cancer cells and kill them. So there's a huge innovation in this setting. So, and the other one is actually the tyrosine kinase inhibitor. And this cancer cell is actually like food and blood supply. There is a lot of fuel support to the cancer cell through the vasculature structure. And there's another way to prevent this vascularization by targeting tyrosine kinase inhibitor. There is a certain receptor that we have been targeting. So, and then like FGFR, VEGFR, PDGFR, CMET, IXL, there is many treatment TKI options available, first, second generation, and third generation, like sunitinib, cabozantinib, lenvatinib, axitinib, and new medication like Tivo and zanzalizumab, and there is like many upcoming tyrosine kinase inhibitor in the horizon as well. So, in the landscape of the kidney cancer treatment, you can see this is a timeline for the kidney cancer treatment from last couple of decades, from 1992, and then we began with the cytokine era, and like interferon high dose interleukin 2, that's actually help cure the patient, but there's a lot of toxicity with this approach. And later, 2005, we have targeted therapy era, which started and targeting VEGFR and mTOR inhibition like sunitinib and sorafenib and everolimus and poziotinib. And that's actually lead RCC into the chronic disease. And around 2015, and immune checkpoint inhibitor like Nivo and Nivo plus ipilimumab launched and actually helped offering the durable response for our patient. And later, 2015, we have a combination approach and TKI plus IO that actually been a standard of care as well. And then we have more options coming actually in Horizon. So there is like a precision next-gen era. Hopefully, we're going to have more treatment options coming. There's a belzutifan option. There is another type of HIF-2 alpha inhibitor, casdatifan. And there is more the third-generation TKI inhibitors. There is some clinical trial that has been designed for neoadjuvant vaccine trial. And there is an antibody-drug conjugate. There's a CAR T cell for the kidney cancer is upcoming as well. So before talking the systemic therapy, I think we need to know what is the risk stratification for those our patient. And this is one of the risk stratification criteria is called IMDC, an International Metastatic RCC Database Consortium. We risk stratified our patient based on their performance status, their hemoglobin level, platelet, neutrophil count, and then the initial diagnosis from to time to start the treatment. So based on the risk, if you have zero risk, technically your life expectancy is higher, and then you can see from the graph here. If you have a zero risk, your life of expectancy in 2 years more than around 80%. And if you have 1 or 2 risk, is around 50%. If you have a 3 and more risk, and life of expectancy is usually less than 20% in 2 years. We still need much better, actually, risk stratification. There is more research coming. Hopefully, we're going to have some more genetic-based risk stratification in the future as well. So the first, I think this is the first line per NCCN guideline from 2026. And you can see for favorable and intermediate and poor risk, there's 4 options available, and those 4 options category 1. But you can start which treatment is actually best for your patient based on their clinical presentation, their performance status, and and the volume of the disease. So the first trial is a checkmate. So 214, Nivo and ipilimumab. I think this is one of my favorite trials. There's many reasons why I say it's favorite, because there is more data available for this trial. As 8 years survival data, we have it. So you can see there is like over survival and PFS benefit and durable of response significantly higher in the Nivo and ipi versus sunitinib. So you can see significant HR ratio over there as well. So the more, I think I move quickly. This is the another graph regarding intermediate versus poor risk patient, and then you can see there is a huge separation and durable response part in the right graph that you can see significant improvement with this combination. So this table technically telling us, because initially I think this combination has not been approved for the favorable risk per NCCN guideline. I think the NCCN guideline just changed his indication criteria recently because of this data. They're able to show favorable risk patient has I think like 13% complete response. Like it was like almost, the patient who got this combination, even there is no overall survival data with this combination, but the patient who got this combination has much better actually complete response. That's lead to approval of this medication per NCCN guideline for favorable risk patient as well. So, but the challenging part about this drug is immunotherapy associated side effect management, right? I think, you need to really discuss with your patient, whenever. So I think most of you guys already know what's the immunotherapy-related side effect. This can be challenging sometimes to complete the treatment, have a maintenance treatment as well. The significant side effect that you may have it is more more like a rash, which started like 4 weeks after your treatment, and later you may have some colitis picture, diarrhea, GI disturbance, abdominal discomfort, and you may have some hormonal change because of the immunotherapy, because this activated T cell can actually attack your body sometimes at some point as well. We have to monitor to make sure that our patient not developing significant side effect from this medication. And we have good tools to prevent those side effects. And if you know what's expected side effect, you're going to have it over time. And then if you let your provider to know, it's very easy to prevent those side effects from the beginning before it gets worse, because we don't want like long-term interruption because of the side effect. We can manage from the beginning, and there is a high chance that we can actually control your disease much better with immunotherapy. That's the challenging part of this immunotherapy. And more data about the immunotherapy side effect, this graph is technically telling us, the treatment-related adverse effect with the dual immunotherapy is more common in the first 6 months, and then later those side effects kind of fading off. I think the reason behind this data, because initially we give you double immunotherapy in the 4th cycle. If you're able to tolerate this one, later we just continue with the nivolumab. This is an advantage of this trial as well. And after 4th cycle of the treatment, we just continue nivo. So yeah, like I told, more advantage because of overall survival, durable response, and quality of life. And this combination is also effective as sarcomatoid feature of RCC as well. But the disadvantage is more toxicity here. So what about the TKI and IO combination? Like I told, there is a 3 clinical trial that show benefit of this combination for RCC as a systemic setting. So the first one is a Keynote 426 trial here that you can see, and almost 5 years data available here. There is a benefit of PFS with a significant HR ratio 0.69, and then overall survival benefit with the significant HR ratio 0.84, and Pembro and axitinib really work well versus sunitinib. Then, and the right side, the right graph that you can see, there is overall survival benefit, almost around 60% versus 39%. Is a huge improvement with this combination. And the next trial, let's see if I move fast. Okay. The next trial is the Checkmate 9ER. So it's the pembrolizumab, actually nivolumab and cabozantinib. That's also around 5 years data is available here. That you can see the PFS and overall survival data is significantly higher in this combination versus sunitinib. And in the graph that you can see, almost 56% of the patients have overall response rate versus 27%. That lead approval of this medication as well in the systemic setting. And the CLEAR trial, and there's another trial that's a pembrolizumab lenvatinib, and around like 4 years data available, and there is a benefit of PFS and overall survival. I think I need to mention what's the PFS and overall survival as well, right? So the PFS is the progression-free survival, and OS is overall survival. So when you're on this drug, we do imaging every 3 months, every 4 months, right, to monitor the response of the treatment, right? When you have any event reported, which means any progression of the disease, so we report as an event. So if you're free of this event, which means you have a positive response to the treatment, that's what we call the PFS when we compare with the actual arm versus the control arm. So that's what this means. Overall survival, usually is reported, if the patient dead or if they're alive still, try to compare with the control arm versus the placebo or control arm. So in this trial, you can see the bar graph is showing, Lenva and pembrolizumab has like 70% overall response rate. This is a great drug, it's working well, but to my practice, actually, this combination I'm trying to save for the future, for the later, for our patient. because it is very effective tyrosine kinase inhibitor. It can be very toxic as well. It's not easy to tolerate sometimes. When I have a patient like 75 and 80 years old, when they have a brain mets, this is a drug that I usually try to use it because there is a good penetration to the brain. I'm trying to save this option for the future as well when I exhaust the other option first. So, and this is a summary slide about how to manage the toxicity here. So we use the two different type of drug here, right? Immune checkpoint inhibitor and TKI. So, and when you start the medication and there is a patient developing a certain side effect, the first thing that you suspect actually TKI is the pill, actually. You stop the pill and usually a shorter half-life, and then if the symptom is improved, that's the drug is causing the side effect. If not, and then you can investigate more to look for the immunotherapy-related side effect. So there is a lot of overlapping symptom and different symptoms that you can see here as well. So, and this is basically a summary of those 4 clinical trials. There is statistically significant overall survival data from 4 trials that you can see here. There is a complete response rate around 10 to 18% with those 4 major combination. And I already spoke about the advantage of the double IO, but there is, of course, advantage over immunotherapy plus tyrosine kinase inhibitor. The advantage sometimes when you have a patient who's very sick and crashing because of the disease progression, if you want to get a quick response, sometimes combination of the immunotherapy and tyrosine kinase inhibitors make sense to start from the beginning to control the disease, relieve the symptom, and then go with it instead of starting double immunotherapy, because the immunotherapy takes time to work. When it's really work well and durable response, we have much more longer data. But when the patient really is suffering from the disease, it's better to start actually the pill plus immunotherapy option together. But the disadvantage of toxicity, sometimes it's not easy to tolerate TKIs. So this is I don't know if I have enough time for. I think I have limited time. Maybe I should pass the second options. There's many second options available. I mean, there is no preferred option, but we try to use our second option based on what they have been exposed. If they have exposed to the IO, we try to use the TKIs inhibitor. If they're exposed to TKI and IO, we still can use some of the TKI, like I told them, lenvatinib and cabozantinib. So, and this is basically summary of the second-line treatment. Instead of talking detail about each trial, I think this is the summary that will help you. I think the only thing that I would like to talk maybe belzutifan, which is another type of drug that's been approved for the second line or third line for the RCC. And the way this actually drug is working, blocking the HIF-2 alpha inhibitor, and then there is a VHL gene, and then HIF-2 alpha. I think this is also this discovery, the VHL protein, and the mechanism of this protein lead the Nobel Prize in 2019 as well. And then when you have a mutational VHL gene, and your HIF-2 alpha is still actively triggering some angiogenesis proliferation, and that's why some of the smart scientists come up with the idea block this protein by giving you belzutifan to prevent the progression of the disease as well. So the trial is, this is the result of the trial. We have a PFS benefit. The overall survival benefit is still maturing. There is no safety signaling with this medication, easy to tolerate. Sometimes anemia and hypoxia is the most important side effect from this medication. So this is a sequence of advanced RCC treatment here. And then we have a lot of available clinical trial in our institution for our patient, and there is more treatment options coming. And then this is some of the summary that we have here. So, and then I think for rare kidney cancer tumor that we have some clinical trial as well. And this is pipeline and selected pending trial is going to come to our institution. You can see there is many trials that we are working on it to get in our institution. One of our rising star, Dr. Hassanov, is working on those. He's going to be our keynote speaker right now this afternoon. So there's many trials coming. So there is also adjuvant treatment option available when you have a surgery, your kidney has been removed. We still have an option to offer you a treatment as a prophylactically prevent the progression of the disease. And there's many study has been done with the TKI. None of them show any overall survival, but we have only sunitinib that shows some DFS benefit, not overall survival. It's very toxic, we don't use it. That's why we come up with any immunotherapy role in the adjuvant treatment. There's many trial has been designed. The only one that actually shows benefit is the pembrolizumab. There is a PFS benefit or survival benefit that we offer our patient when they have a high-risk disease. And this is the trial detail. You can see the high-risk means when you have a kidney has been removed, if you have a T2 disease sarcomatid feature, high grade, T3, T4, they have a lymph node involvement, if they have a metastatic disease has been removed, they are a candidate for adjuvant immunotherapy. When you have your treatment, your kidney has been removed, you have a high risk, you need to see the oncologist to start the adjuvant treatment. So, and this is the data that we can see. There is a DFS benefit and the different risk group as well. There is an overall survival benefit as that you can see here, which has been published in New England Journal of Medicine like a year ago, and that's actually approved by FDA as well as a treatment option. So, and then there is one more treatment actually, is most likely is going to come out because this trial just presented in ESMO last week on Saturday that has some benefit of using double immunotherapy option. So we're going to have more data coming to us. And there is adjuvant treatment option available. Dr. Singer is running this clinical trial for adjuvant treatment. So hopefully we have this option available to you. Combining the immunotherapy with the TKI is a very good option. TiVo is a third generation TKI. It has unique effect. Hopefully we can enroll more patients to this trial to have some more option available to us as well. So the conclusion here, basically, the frontline treatment, we have many options available. We can pick up based on the patient presentation and clinical picture. So if there is a sarcomatous rhabdoid feature, double immunotherapy is the best option. And then post immunotherapy and tyrosine kinase inhibitor, we have belzutifan option. Should know that there is an adjuvant setting, and adjuvant pembrolizumab is a good option as well. Thank you very much for your attention. Really happy to be here. I think this opportunity was a great opportunity for me to present this topic. I tried to do my best to present in 20 minutes. Hopefully you guys learned something. Any question, we'll be happy to answer it. So I also actually developed some AI created video for the IOTK for you as well. I don't know if you want to play the video for the patient as well.
These new IO and TKI treatments specifically target the cancer cells. Look!
Wow, they're working! They're destroying the cancer!